we found in all these 3 states is that the internet facilities has reached at least up to all community health centers, not to the primary health center, but wherever CHCs are there, it has reached. Then coming to the equipments, again, because ultimately it determines the productivity of the doctor. When he goes from a medical college after working for 6 to 10 years in medical college, reaches to the peripheral facility, he needs all this, but sometimes they are there and most of the time they are not there, or for one or other reason, even if they are there, they are not functional, which includes the delivery equipments, the OT lights, and the boiled apparatus and different other things. Then the issue of training. Throughout all these 3 states, we found that induction training does not occur. While the induction training does occur for all other civil services, when people for the other administrative services are inducted into the system, they are not sent to their offices, they are never sent to the cutting edge, but they are always given 3 to 9 months induction training. But for doctors, it so happens that even in the name of induction training, it occurs after when they are in service for 2 years or 3 years or 4 years. Most of the time, it is virtually in-service training. Then there is a lot of confusion between in-service training and CME. We interacted with some of the civil surgeons who assumed that a CME on a particular subject is also assumed to be the in-service training. So largely trainings are not based on the training need assessment. None of these states had a concrete training policy. Then most of the trainings are project-based. State government in their budget, they never budget the training. They totally depend on Government of India on different projects, World Bank funded projects or different other projects, and whatever funds come in those projects. They are the only basis of the training. Otherwise, training as a regular and a mainstream process is never thought of. It is always project-based training. And last but a very critical component of training in health is, in health there are a lot of compartments. Like AIDS Control Society in different states have altogether a different training mechanism. The communicable diseases, or for that matter, disease surveillance project will have different, NRHM will have different, and public health will have different mechanisms, and same people keep on going, and most of the people not going in any of these trainings, saving themselves from any of these trainings. Then the other thing is that the diagnostic and therapeutic facilities at the peripheral facilities also matter a lot. Now coming to the main point, that now we have completed 5 years of NRHM, and the policy, which today's policy says that by the end of this mission, all facilities in this country, all peripheral health facilities in this country should be at an optimum level, the Indian public health standard which has been decided. But this is a point, this midpoint, this is a critical point when our policymakers must think of it, how much it is in reality it can occur. I am only quoting example from one state. The population of the Jharkhand state as on this year, because now census will occur and it will be around 3.5 crore, close to 3.5 crore. And the actual PHCs are 330 in the states, while as per IPHS standard, 1100, more than 1100 are required. Same for CHC, you can see almost 265 are needed, while there are 194. And the number of doctors, almost 400, 500 short, as far as generalist is concerned. And for a specialist, it is an illusion. That as per IPHS standard, more than 1800 specialists are required, but actually there are only 188. So the point is how to strike a balance. Whatever evidence is there before us right now, how should we use it in making our policies more judicious? Our sub-centers throughout this country are loaded with female staff. Male workers everywhere are on extinction. Almost most of these health professionals, because we encountered in these 3 states, 60 to 90% of the employees said that they are not aware of their job responsibility. Whatever is being directed to them, they do it. So job responsibilities are not very well defined. The project management unit, which is a new culture and a new organizational ethos coming after NRHM at the state level, at the district level, and now at the block level, is also creating ambiguity in the sense that those employees who are in the mainstream for decades together, they find a lot of conflict when they find a lot of contractual people around them. So it has to be taken care of. Then other important issue is that there are no well-defined referral linkages. Up to what level primary health center has to function, up to what level CHC, and then the other is balancing the national health program, and lastly reviewing the undergraduate education. So these are the important issues which have come up, and I hope that they can be of better use if they reach us to the policy planner, and can help